LRP with articulating laparoscopic instrument, ArtiSential. I'd like to welcome Dr. Duke Harrell and Dr. Shang-Xio to the podium, who will serve as moderators for this session.
Thank you, Chairman. Good afternoon. I'm Jongwook Park from Korea Cancer Center Hospital. Thank you for giving me this precious chance to share my experience with LRP with articulating instrument ArtiSential. First, I'd like to know that I'm going to talk about this surgery, pure laparoscopic surgery, though we are in the robotic surgery session. The laparoscopic radical prostatectomy, or LRP, has been considered one of the most challenging surgeries in the urological field. In an earlier report in the late 1990s, Dr. Louis Cavusi, a pioneer of LRP, even mentioned that LRP was feasible but currently had no advantage over open RP. Another renowned laparoscopic surgeon, Dr. Guillaume of France, also said that the improvement of instrument was necessary for LRP to be technically improved. Despite these limitations, LRP has become the minimally invasive surgery for prostate cancer for decades. However, the advent of the robotic surgical system has made laparoscopic surgery easier, and the robotic radical prostatectomy has become a mainstay in developed countries. On the other hand, due to the high cost of adopting and maintenance of the robotic system and the high cost of the surgery, it is difficult for all hospitals and all patients to use the robot. ArtiSential, an articulating laparoscopic instrument, can overcome the shortcomings of conventional laparoscopic instrument due to its increased degree of freedom through joint movement. At the same time, it can be performed at a much lower cost than robotic surgery, making it an excellent alternative to robotic radical prostatectomy. Here is our case. A 73-year-old gentleman presented with a PSA of 12.1. He had a palpable hard nodule on the right side of his prostate in the digital rectal examination. A multiparametric MRI showed a PIRATS 4 lesion in the right peripheral zone, and an MRI targeted biopsy revealed Gleason score of 7 to 8 adenocarcinoma in the right lobe. His gallium PSMA PET showed no metastasis, so he decided to undergo LRP. These are the instruments used during LRP. I always use the ArtiSential monopolar electrocautery scissors, and ArtiSential bipolar forceps, and ArtiSential needle driver. I use only one needle driver in RARP as well. And this is a trocar configuration. A camera port is placed above the umbilicus, and two more trocars are installed on each side in the fan shape. So this is a video clip. Yes, first of all, by making an inverted U-shaped incision on the anterior peritoneum entering the radius space. My right hand was holding the ArtiSential monopolar scissors, and my left hand was holding the ArtiSential bipolar forceps, and those instruments were inserted through the two left-sided trocars. The bladder was filled with air to ensure the boundary and prevent unintentional bladder injury. Earlier, I filled the bladder with water, but the bladder drooped downward due to the weight of the water, making it difficult to distinguish the boundary of the bladder dome. So nowadays, I fill with air instead of water. After the dissection has progressed to a certain degree, the air in the bladder is drained. So the procedure for this surgery is almost identical to that of the robotic prostatectomy, so it may not be necessary to explain each step, so as you know better than me. So if you have any question watching the video, I'm happy to answer. This patient had some adhesion between the bladder and the pubic bone, and after cauterizing the superficial dorsal vein, the pre-prosthetic fat was removed. Yes, and after changing to a 30-degree scope, started cutting the bladder neck.
I have a question. Who is assisting you? Because with this device, obviously you have somebody controlling, I guess, the camera as well as the suction?
Yes, I got one assistant. He's a male nurse, and he's grabbing the camera in the left hand and also doing suction with his right hand.
Yeah, the reason I asked that is because I think some of us use the assist to use two hands. So, and this person is using two hands, but he doesn't have another hand available. So you're a little bit limited on the number of instruments maybe you have available to you compared to a robotic, like a true robotic approach.
As you can see, the Foley catheter is fixed, and that's, as a matter of fact, it's fixed in the drape with some kind of tape, because we don't have any more hands.
You have another port there. What's going on with that port? Is that just locked grasper? What's...
Yes. And at this point, as you can see in the video, unlike the conventional instrument, being able to use the joints to point the scissors downwards at a right angle makes it possible to avoid unintentionally cutting and entering the prostate. Yes, and I'm now picking and dissecting a vas deferens.
Hi, Dr. Park.
Yes.
Is it grip strength of this ArtiSential is similar to the conventional laparoscopic instrument?
Yes, I think so, because we don't have any apparatus to strengthen the gripping force in this instrument.
It's a very pretty dissection. If you just took away the right side of the screen, you might think you had a robot. So beautiful. Can you comment on the ergonomics for you as the surgeon? I did a lot of lap prostates, and it was very tough on my now old back. How do you feel about the ergonomics of this? I notice you're leaning forward into the table quite a bit. You're not quite putting the amount of torque that we had to do with shoulders and reaching across, but certainly it's still not as ergonomic as perhaps sitting at a console. So thoughts on the ergonomics and body cost to you for doing this approach?
Yes, I totally agree with you, and that it's totally, as you mentioned, the poor ergonomics of laparoscopic surgery is well known, and as you can see, this instrument has a quite large head, handpiece, and that the weight of this instrument is about 370 to 380 grams, and that's about 4 to 5 times of conventional instruments. So once you grab this instrument, you can feel, oh, it's very heavy. But if you use this instrument over and over, maybe you will later enjoy the heaviness. Yes, and you know, as you can see, with grabbing this instrument, and you have to rotate your wrist and arms to approach in various degrees. So I think that makes some stress on your tendons, especially in your wrist. So that's ergonomically poor side.
Some of the earlier versions, I'm not sure it was the same company, strapped this to your forearm, and then you made moves with your wrist and hand. This looks more ergonomic to me than those original versions. I noticed when you have it in, you're almost at the limit of your port a lot of the time. Do you ever have trouble reaching, or do you have to worry about port placement in terms of the length of the actual instrument?
Yes, you know, because the head of this instrument is very large, and so that there may be some kind of a collision outside a patient, especially doing suturing with a lot of movement. So that's a point of a drawback of this instrument, need to be improved. But unlike the robotics system, you can move your instrument or even camera from this draw car to that draw car. So when you're facing the collision outside, you can avoid in this way. So yeah.
Dr. Park, have you experienced any complication related to the handling or manipulation error of this instrument?
Yeah, well, I can see you later in this clip, but so far I experienced one rectal injury during this laparoscopic radical prostatectomy, but actually it was not a fault of manipulation, but the patient had very severe adhesion between rectum and prostate, so I didn't have any complication or from the malmanipulation.
Can you clarify what activates the current for the bipolar or monopolar? What activates it? Is it a pedal or is it?
You mean bipolar forceps?
For the current itself, how do you burn?
Yes, I got a pedal.
A pedal?
Yes.
Okay.
You're demonstrating a prostatectomy here, which I think is probably one of the hardest surgeries to perform robotically, laparoscopically. Are you using this for other, partial nephrectomies and such, or is this simply?
Of course.
Yeah. So you've chosen to show us probably one of the hardest laparoscopic surgeries you can do, which you're doing a very good job of.
Once again, a beautiful dissection there. I mean, can you comment, and I know it won't translate across all the different economies, but these are disposable instruments, right?
Yes,
one
these are
use
disposable, yes.
And cost-wise, can you?
Yes. Well, the Korean National Insurance reimburses these instruments, and it costs about $400 in US dollars each. Yes, single use. Well, it already passed away, but I sutured the dorsal vein complex with this instrument, but before with the conventional laparoscopic needle holder, for me, it was almost unable to do the dorsal vein suture in this narrow and deep area, but thanks to this articulation, now I feel free, yeah. And also doing anastomosis. I'm using a double arm suture, double arm barbed suture with different colors, not to confuse the left and right arms.
I did some early work with the tubing and radius, which was something like this, more mechanical out of tubing. And did you find, how is this for your hands as well? I mean, do you wind up just with exhaustion of your hands from manipulation through these cases? I mean, it's obviously a lot more for your hands and arms. Not as bad on your shoulders, I think, as normal lap equipment, but can you comment on that? Or could you do 2 or 3 cases in a day with this? Or could you do, okay.
No, so far I'm doing only 1 case a day for this LRPs because we do not have many slots in the ORs. Yeah.
That's universal.
So you have a lot of movement, degree of freedom at the tip. I cannot fully comprehend how you get the angulation at the tip of the instrument. Is it just with your wrist moving?
Yes, this follows my wrist, the motion of my wrist and hands. So yes.
Dr. Park,
Yeah.
how much experience is typically required to become a proficient this instrument? What is your opinion?
I started using this instrument earlier last year, and as a matter of fact, in initial some cases, I converted to. I started using in anastomosis, but in some cases I gave up and converted to conventional instrument. But reflecting my experience, I think I felt comfortable after 15 to 20 cases. Yes.
What was your previous experience before that with straight stick laparoscopic prostate? 100,000, what?
Before this, I have almost 200 cases of LRPs with conventional. Yeah.
And having done a few lap prostates a long time ago, I found the anastomosis was by far the most challenging part laparoscopically. Do you find this is improving that part the most? Is that where it's helping?
Yes, absolutely.
Do you have a robot at your institution, or?
Yes,
and what,
of course.
What type? Or
we have RevoEye. That's a Korean,
Yep.
Korean brand. Yes, and also, I also use that robot system. So for me, the ratio is 50-50. For 50 for half robotic, half LRP. Yes.
And what determines that in your practice?
Well, mainly patient's preference.
Okay.
Yes, I don't recommend any robotic surgery or LRPs because, in part, Korean national insurance reimburses LRPs or RRPs, but not RARP. So, if the patient has a not rich or not a good economic condition, patient may choose the LRPs. But some patients want robotic prostatectomy, yes. So if patients want robotic I do robotic.
Have you looked at the difference in time for you?
I'm sorry?
During the difference in the time of the OR time
Oh,
between
yeah.
you're doing a robotic approach and this approach?
Oh yeah. Essentially, I found no difference between LRPs and RARP. Yeah.
Oh, were there any some difference in surgical outcome over your LRP between ArtiSential and conventional instrument?
Yes, that's a good question. Because my LRP experience with ArtiSential is not so much, so I'm currently analyzing the results, but still I didn't find any differences in oncologic outcomes or functional outcomes yet. Yes, but I need some more follow-up period.
Are there any patient factors that figure into the decision for you with robot versus this approach? Anything about BMI, obesity, any other things, or do you feel comfortable offering either?
Yes, I think BMI is one of the important factors, but you know, we don't have many obese patients in Korea yet. So
I can send you a few from Tennessee.
Thank you very much.
thank you. Get any questions?
Any question for the doctor?
Dr. Park, how do you expect the future of this ArtiSential instrument?
Oh, well, yes. From my experience for more than 1 year, this is a very good instrument, but still some points to be improved, like weight or size, and also this shaft does not rotate. So if you like to approach in the right angle, you have to rotate your whole arms with grabbing this instrument. So that makes some stress into your arms. But I think I heard that this company is researching and improving that point. So later, this will help laparoscopic surgeons with yes, much. Yes.
What do you see as the future for this? Clearly, a lot of us in this room began with pure laparoscopy, and it was quite difficult. This is making it a bit easier, but what do you see as the future?
Future is difficult.
Hi, I'm Wilson Chan from Hong Kong, and this instrument is available in my center, and we want to start the first case. So what case will you recommend to start, like radical nephrectomy, radical prostatectomy, or cystectomy? Thank you.
Oh, well, yes, that's a good point. For me, I don't have any radical cystectomy experience with this instrument so far, but without radical cystectomy, I did almost all laparoscopic surgeries, even malignancy or benign diseases. But for beginners, especially with this instrument, I would recommend renal cyst decortication. That's safe and short time, and will not give you much stress with this instrument. And
Might also be nice to try like a pyeloplasty just to get the handle on suturing from different angles. I think that might be a good, safer case that gives you some experience.
Absolutely.
Just a comment, great demonstration. I think it proves the point I make often, that motivated and talented surgeons can get all sorts of techniques to work and look good, but that's a different concept than what's reproducible across a large number of surgeons. And to me, I think you'd have to solve two issues. I think for most of us who did both techniques, going back to an unsteady camera for me is a no. I'm not doing that. But that could be solved. I mean, remember we had was it ESOP way back when? There are ways to get stabilized vision non-robotically if you need to. And I would have a hard time doing a complex case like that without an articulating third arm in terms of the exposure additions it provides. But I almost wonder, to Gayan's point, is this even the best indication? I mean, I have some of my colleagues in general surgery do lap hernias and hardly even use the third arm, and it's a quick retzius dissection with plugging mesh, and I think there's plenty of opportunity for those type cases. But these things could be solved over time.
Thank you.
Yeah, I think it's going to be really interesting to see with some of the new robotic platforms that are emerging that have some of their instruments are designed in a way that's much cheaper than some of the instruments that are out there right now. There's a company, Distal Motion, that's working on a platform that uses some really interesting ways to make the instruments less expensive to manufacture. And so we'll see what happens. We're sort of in a technology cost race right now in robotics. So.